afternoon, everybody. I'm Lisa Napolitano, founder and president of the Florida Cognitive Behavioral Therapy Association. And on behalf of FLCBT, I want to welcome you to this webinar, which is part of a series of professional training workshops that we're offering by experts in our field. In the coming months, we'll be offering trainings in motivational interviewing, compassion-focused acceptance and commitment therapy, and inference-based CBT for OCD, to name a few. So if you haven't already, please check out our website for upcoming events at floridacbt.org. And if you're a mental health practitioner in Florida, I hope you'll consider joining us. Today, I'm very pleased to introduce my colleague and friend, Trent Codd III. Trent is a native Floridian, I should mention. He is currently Senior Supervisor and Clinician at Cognitive Behavioral Therapy and Assessment Associates, a group practice in Manhattan. Prior to this role, he was the Executive Director of the Cognitive Behavioral Therapy Center of Western North Carolina, a multidisciplinary group practice specializing in the provision of evidence-based mental health care, a practice he founded in 2001. Trent completed his graduate work at the University of Florida, and he has extensive postgraduate training in several empirically supported treatments. He is a Diplomate, fellow, and certified trainer consultant for the Academy of Cognitive and Behavioral Therapies. He's intensively trained in RO DBT and an approved trainer. So Trent, thanks so much for being with us today, and I'll turn the floor over to you.
Great, thank you so much. And thank you for the compliment of asking me to come talk to everybody about this topic. I really appreciate that. And just a quick note, everybody, I will definitely be available for questions. I'll carve out some time at the end of this in order to receive your questions. And the thing I always say to everybody is, even if you have questions after this, you can always contact me. I love to talk about this stuff. So if anything, getting me to stop talking about it is probably the bigger risk. Let me jump into it then. So first, we need to think about, in some ways, we're at a crossroads, but in some ways I'm saying, I kind of feel like now we're sort of moving into the middle of the crossroads. We've made some progress in this. We've got a number of issues going on in psychotherapy treatment. First, we have a significant proportion of people who fail to benefit from our existing treatments, particularly due to the chronicity of their various conditions, comorbidity, and pre-existing personality functions. Even if they don't rise to the level of a personality disorder, there are some personality characteristics that can impede effective treatment. And one thing that a lot of people don't, I think, really appreciate is how common personality disorders actually are. So in the general community, it's about 1 in 10 people. And if you look in different settings, like primary care medicine settings, it's between 10 and 20% of people who are going through primary care have a personality disorder. And in general outpatient settings, general outpatient mental health, you're looking at about the estimates obviously vary, but they hover around 30 to 40%. That's quite a bit, right? And of course, in places like prisons, it's even higher than that. 70 to 80% is a very common thing. One thing I'm going to ask, and I'm just because of the nature of the format that we're speaking in today, I'm just going to ask this rhetorically. So you don't need to obviously answer this, but think to yourself, what do you think is the most common personality disorder out there amongst personality disorders? And I'm going to go out on a limb and say that most of you probably think it's borderline PD. And if you didn't say borderline PD, probably another cluster B. It's actually not true, believe it or not. And later, in a few slides, I'm going to talk about why you were likely to think that, because we think that's a big part of one of the problems that I'm hoping to help solve here. In reality, the most common personality disorders are what we're referring to as overcontrolled PDs. And you're less likely to notice them, again, for reasons that I'll explain shortly. So personality issues are common is the message there. Existing treatments are often not effective, or I should say effective enough. And just to give a couple of examples, depression, you might have heard of or hear of the law of thirds, that, roughly speaking, about a third of people who are depressed experience, favorable responses to our treatments. About a third experience partial response, but remain symptomatic, and about a third aren't helped at all. And it gets even worse when you look at other conditions like, say, anorexia nervosa. The outcomes are generally pretty compromised. And complicating this further is that most of the empirically supported treatments we have been tested on non-chronic and non-comorbid conditions, right? And a lot of the difficulties, even if there isn't comorbidity there, is screened out, right? Like self-injury and so forth. However, as you know, I'm assuming most of you on this call are actually out there practicing, seeing patients. That's a problem, because the typical or the modal type of patient coming through your door most likely is experiencing comorbidity and chronicity and these various kinds of problems that are screened out in a lot of trials, right? So a lot of problems. This is not an exhaustive list, of course. And many people have recognized this problem for a while. Certainly within the cognitive behavioral community, I think this is not necessarily a new idea, right? That this is an issue. Funding agencies, major funding agencies, have relatively recently started to recognize this issue too. And they're starting to pull for a couple of things to help solve this problem. And one is they're interested in transdiagnostic models, which, in the way that they're discussing that, involves theory and research that integrate biological science, which you actually know quite a bit about, with behavioral science. And they're also very interested in looking at new ways of classifying psychopathology. There's a number of ways of doing that. I mean, one that seems to really be picking up steam is the high top model, if you're familiar with that, partly to resolve a lot of the problems that come along with DSM-5 in particular. And then, of course, transdiagnostic treatments that relate to that is also a big interest. And in particular, they're interested in treatment approaches that account for shared genotypics, so the sort of the genetic and biological basis, and phenotypic features, or the overt behavior or how it's expressed, rather than focusing on diagnosis specifically. And as you'll understand shortly, RO DBT certainly falls into both of these buckets, both as a transdiagnostic model and transdiagnostic treatment. Okay. So let me just now talk a little bit about, give you a little bit of an overview of the research status of this and where things are looking at this point in time. So really, even though it's relatively recently been in dissemination, and it's hard to pinpoint an exact date, but I'm going to say roughly 2016 is when it really started to be disseminated, and then it kind of hit a pause button when COVID hit, and now it's starting to be, the dissemination efforts are picked back up. But despite that relatively recent time horizon for the dissemination efforts of this, it's really been around in some form and developed over about 30 years. Okay. The treatment developer is Tom Lynch, who used to be at Duke University, and that's where he did most of this research. He relocated to the UK for a while and was at a university there. And now he's retired, so he no longer has his lab, but he and his wife have a company that's involved in continued RODBT related efforts. It's specifically designed as a transdiagnostic treatment, but specifically for what I'm going to explain in a little bit, is called maladaptive overcontrol. And so which relates to biotemperament and sort of personality features. And so the idea is that is sort of the common variable across a lot of different conditions that produces what we talked about in DSM terms. At the current stage of the game, more than 350 patients have received RODBT in research trials. And let me just give you a basis of comparison. My understanding is that standard DBT, when it was first disseminated, there had only been 22 patients run through research trials. So and this is not a slight to DBT. This is to provide a comparison to how far along RODBT is in that regard. And of course, there's been thousands clinically. And I realize there may be varying degrees of psychotherapy research knowledge on this call, so I'm just going to forgive me if you already know what I'm about to say, but just to make sure everybody's on the same page. Generally speaking, there's two different types of research trials. There's efficacy and effectiveness, and there's something called the efficacy to effectiveness pipeline. And in general, you start out with efficacy type trials, which basically tell you under tightly controlled conditions, does the treatment seem to work? And then you sort of progress into effectiveness trials, which kind of answer the question of, does it work in real world conditions where there's a lot of noise and a lot of mess, essentially, right? And to establish efficacy, the floor typically is that you have to have at least two randomized trials in which the treatment is compared to a control condition and found to be superior, of course. And at least one of those two trials needs to occur without the treatment developer's involvement. Okay. And then effectiveness, again, the typical way, the way that's established is typically through an open trial, which is where there's no control condition and you're, of course, engaging in pre and post measures. All right. So that's the floor for saying something basically is evidence-based. And at this current time, there are 3 randomized trials for RO DBT and 5 open trials and a range of other kinds of empirical data that I'll highlight in a bit. And much of that work has been done outside of Tom Lynch's lab or with his involvement. So I think we're on pretty good footing there. And the evidence base extends across a number of populations, including the age range. Even there's a lot of work being done with young kids. And as I'll talk about, this sort of maladaptive overcontrol pattern, you can start to recognize as early as 4 and 5 years old. So you can kind of identify it fairly early. And across a range of diagnoses, most commonly what you see here, anorexia, depression, autism, heterogeneous patient groups, but I would also say the cluster C personality disorders is another big area. So let me tell you just briefly a little bit about the history and how this came to be. So I imagine most, if not everybody here, is very familiar with standard dialectical behavior therapy, and which I'm certainly not an expert on, by the way. I know we all think about it as a treatment for borderline PD, which it is, but my understanding is it was originally developed to treat chronic suicidal behavior. And of course, they map onto one another to a large degree. But in essence, as you know, that population is characterized as having poor impulse control, emotion regulation difficulties, chaotic interpersonal relationships, a lot of dysfunction in that realm. And that treatment was designed to target those kinds of things. And so what Tom Lynch started to do with some colleagues was to try to adapt that treatment for other populations, and particularly and initially for chronic refractory depression, which included a lot of the things that are typically screened out, right? Like highly suicidal patients, for example. And they recognized pretty quickly that the problems that they were seeing in the chronic depressed treatment refractory depression population was quite a bit different than what you would see in borderline personality disorder, what the DBT was designed for. So in other words, this treatment's probably not going to, we can't just slightly adapt it for this population because it's turning out to be a lot different than we thought it was going to be. Okay. And in fact, what is the basic nature of what they discovered? And again, I'm going to unpack this a little bit further as we go along. But essentially, the opposite of what you would see in borderline PD. There's high inhibitory control, a lot of rigid rule-governed behavior, a lot of emotional inhibition, and the nature there was interpersonal dysfunction too, but the nature of the interpersonal dysfunction was different. Those relationships were more characterized by like really being aloof and distant, and a number of other things that had sort of emerged. So, okay, just slightly adapting standard DBT is probably not going to be helpful. It's sort of the thinking. We need to think about this in a little bit of a different way. I have to give you another building block. And before I unpack what you see on this particular slide, there's a number of studies then I'm not going to roll out one after one. I'm just going to tell you the upshot, basically, right? The estimates are going to vary across studies, but they're all going to hover in the same general vicinity. So the take-home message is essentially the same. What you find when you look at, and I'm just going to stick with depression for a minute, treatment-resistant depression populations is, again, high degrees of comorbidity, and in particular, comorbidity with personality disorders. That's a big, important thing to understand. So one sample that I think is fairly representative, it was part of a randomized trial I'm going to tell you about later called the Reframe trial. Only 4% of the patients, and by the way, there were 250 patients in that trial. So out of 250 patients with chronic, refractory depression, only 4% failed to meet criteria for at least one comorbid condition. I mean, wow. I mean, that's amazing. And then 87% of those who did meet, which was again most of the people who did meet criteria for a comorbid condition, met criteria for a syndromal disorder, what we used to call axis 1 disorders, and 79% met criteria for a personality disorder. So the main takeaway is you're dealing with difficult to treat populations. There's absolutely very likely to be lots of other problems there, but particularly in the personality realm. Okay. So now taking a look at this, the slide that I have here, this was from the second randomized trial that they did on RO DBT for chronic depression. And again, same story in terms of the comorbidity, basically speaking. But what I want to highlight now is within the personality disorders that were present. This is how it breaks down. This is the percentage of patients in that trial by personality disorder type. But the take home here is, bam, 73% of these had over-controlled PDs. And I know I haven't defined over-control for you yet, but just think cluster A and cluster C. Although I often ignore cluster A because I don't think they really make their way to treatment very often. So it's mostly cluster C, but we might think about A and C as being over-controlled and cluster B as what we would call under-controlled PDs. So if you're not targeting the personality features, you're unlikely to be very successful, right? Is kind of what we're learning here. So early days, it wasn't called RO DBT. It was just called DBT for emotional overcontrol. So sometimes you might still see that language in the literature. As I've already explained, that sort of variant idea was abandoned for various reasons. But one of the problems is dissemination was an issue. So a lot of people that were trained in standard DBT would come to get the training thinking it was just a slight, tweak, that they might learn, but it's actually evolved into really a completely different treatment, even though it still has dialectical behavior therapy in the name. So that was an issue. And then also, as they're writing about RO DBT and submitting, empirical data for publication, a lot of reviewers and other experts around the world would kind of say, this is really not standard DBT. This is a completely different treatment. And including this includes the publishers, New Harvard, who ultimately published the main textbook. And then, so the conclusion was we need to rename it because it's causing all this confusion. But Tom wanted to leave dialectical behavior therapy in the name because of the history where it emerged from, but it does also still contain some dialectical elements, though they're different from standard DBT. There's different dialectics. And of course, it is a behavior therapy. So radically open dialectical behavior therapy was born as the name. That's the history there. There's lots of differences between the two treatments. I won't have time to really distinguish them because they are distinguishable in many ways. If you are interested in that later, I'm going to give you a link to a place where you can access resources. And there is a free webinar that specifically speaks to this. All right, so now let's just take a look at bird's eye view of overall research that's been done on RO-DBT. And I'm going to start by talking about refractory depression. I mentioned already that there are 3 randomized trials, and there's one I'm going to unpack a little bit because it's important for you to understand. But the takeaway is it works. But first, in the first two trials, the 2003 and the 2007 study that you see here, they were able to realize believe it or not, it was actually the same percentage, 71% remission at post-treatment. I don't know if you've seen this meme that's been going around some social media outlets. It says something to the effect of life is short, so try to spend all your time arguing with random strangers on social media. Unfortunately, I get sucked into that, and I got sucked into that just this last week on LinkedIn. There was a psychiatrist, there was a whole thread about refractory depression, and there's a psychiatrist who apparently does some research and is really interested in short-term psychodynamic therapy, posted that the highest trial to date of any psychological treatment has only achieved a 40% remission rate. And of course, it was his short-term psychodynamic stuff, right? Well, actually, in 2003 and 2007, we have these two studies that showed 71% post. Now, at 6-month follow-up in the first study, it increased. And then in the 2007 study, unfortunately, it decreased a bit, but went down to 59%. But that's still pretty doggone good. Notably, in those two trials, they were also able to show movement on the personality dimensions, which I think is super, super important. The biggie, and unfortunately, somehow my kids must have like played a joke on me by programming the animations to like auto advance because I wasn't clicking the button when this happened. So unfortunately, whoops, that first little thing that you see there, thought bubble, that's pointing to the third trial is to me super impressive. So and I want to make sure everybody's on the same page. An effect size measure, for those who don't know, basically speak to the magnitude of the effect. And I think that's way more important than even if something being statistically significant or there being a difference, because that doesn't tell you anything about the magnitude of the treatment effect that you're seeing there. So I think what really matters in my mind is effect size measures. And in that trial at post-treatment, they showed a very large effect size of 1.03. And as far as I know, I don't know everything, obviously, but as far as I know, that's the largest effect size ever reported from a psychological treatment for refractory depression. That's a pretty impressive value. Okay, so then also there are into the eating disorder area. This is another area where I know nothing about eating disorders, so let me just give you that. I've only learned a little bit about it because of my contact with RO DBT. So if you're an eating disorder person, I say something silly, forgive me. But my understanding is that anorexia has generally been almost impossible to really treat effectively, and that the dominant model is a family-focused type approach. And I think it's called the Maudsley family-focused therapy or something along those lines. Well, they're doing RO DBT at Maudsley Hospital where that treatment was developed. And in fact, I don't know if you can see my cursor is like a pointer. These last three authors here, Julian Bodine, Martina Isaacson, they actually work at Maudsley Hospital and are doing some of this work. So one area where there's a ton of interest in RO DBT has been in eating disorders. And as you can see here, we have 5 open trials with various kinds of samples, inpatient, outpatient, adults, adolescents. And you can see the very first little thought bubble that got ahead of my message was an effect size measure for BMI. And I'm told that is the largest effect size to date on that particular value. Then there are 3 non-randomized trials for adults and adolescents that are only using the skills component of the treatment with favorable results. One thing that's big these days, as you know, is there's a lot of interest in what are the actual mechanisms of change in any particular treatment. If you think about most psychotherapies, there are these large composite interventions with lots of things, a lot of moving parts. So like what is actually responsible for the thing that we see? So there's a lot of prioritization these days at looking at mechanisms of change. And here's one study that I was very happy to be part of where it's a secondary analysis where we took the data from the largest randomized trial they conducted and looked for these mechanisms. And the upshot, the take-home message is that yes, the 2 key proposed mechanism of change, which is psychological inflexibility and interpersonal dysfunction. I'll have to explain to you what we mean by that in a bit, actually do seem to be the drivers of the change in this treatment. So that's nice. We know that. Other studies, there's some on children, as I mentioned earlier, and one of the big drivers there is Kirsten Gilbert, who's just doing phenomenal things in that world. She's even developed some child-specific measures to measure maladaptive overcontrol, which is really, really important. And there's an implementation study that was done at Rowan University in New Jersey. If you're interested in accessing any of these papers or keeping up with the papers that come out, and I'm going to send up my slides later, by the way. I'm going to give them to Lisa and she's going to send them out so you can access these resources. I'm sorry I didn't say at the beginning. You can navigate to that link as papers are published. They're listed there. Okay. So does it work for depression? And I've mostly unpacked this, and the answer is yes. These first two boxes here are related to the first two studies that I told you about before. The first one's referred to as RO DBT early. The second one is RO DBT early 2. And you can see the remission rates that I discussed with you. What I didn't tell you before was that the comparison condition was an active treatment condition, and it was in the first study, antidepressant medication. And in the second study, it was antidepressant medication plus general psychiatric care. All right, then the third box that you see there is from the reframe trial that I'm just going to briefly tell you about now. To me, it's really impressive. So it was the third trial that was done. And by the way, I should probably mention, as you might imagine, as we go across trials, the treatment was further refined and developed, and the manual modified a bit, and sometimes new targets were discovered to be important to target. So really, this last box here on the right from this really impressive trial represents the most current iteration of RO DBT as well. Multi-site was done in the UK, and Tom Lynch did train the clinicians, but he had essentially just trained them prior to the trial and was not involved in the data collection process. So he wasn't completely independent, but he was largely independent. And there's a little bit of a I guess you could say a cultural variation to it. I realize that the UK culturally is not drastically different. Sorry that keeps auto advancing. Drastically different from the United States, but there is some cultural differences there. What they did in addition to, and this is so important for me to say. So the comparison condition was treatment as usual, which is a very common type of control condition. But it's more impressive in this case because in the United States, for those of you who don't know, like treatment as usual just means essentially whatever would normally happen. And I don't know about you, but I'm thinking whatever normally happens in a lot of cases in psychotherapy in America aren't necessarily great. Although obviously it's very heterogeneous. In the UK, where this trial was done, treatment as usual is like they have the national health system and they have some guidelines around the treatments that can be offered to patients. They are all essentially evidence-based treatments. So they're not just doing the kind of stuff that goes on over here in the United States. So in my mind, even though it's still very heterogeneous, that's a more impressive control condition to be beating in my view. And they could be on medication too. Like that wasn't excluded. That wasn't an exclusion criteria. So in any case, you can see what I'm saying here, that the RO DBT did really well under those conditions and reported that really large effect size that I mentioned before. Now, let me show you what you see on the screen here. I mentioned effect size measures before, right? So those are the measures that tell you about the magnitude of the effect. And one of the things that effect size measures can do is help you compare treatments. So what you're going to see on the screen here, and I'm going to again use my cursor to point, is right here, RO DBT, the reframe trial I just discussed, that achieved that effect size value I told you about before, 103, which is really impressive. What you see here is something referred to as the Cobalt study. And one of the reasons that's presented here separately is it's the most comparable study to the reframe trial. So it made sense to isolate it and kind of show you in comparison. And this is CBT for chronic depression, right? And they achieved, which is still an impressive value of 0.53, right? But obviously less than RO DBT. And then here we're seeing the pooled effect size value for the 3 randomized trials. And when you combine those, you receive a 0.86. And over here, we have 3 meta-analyses. The first meta-analysis here is a meta-analysis of CBASP. And for those who aren't familiar, that's a specific CBT type intervention specifically designed for chronic depression. So a meta-analysis of that approach is they reported a 0.34. And over here in this meta-analysis, this is a meta-analysis for all psychological treatments for chronic depression, 0.23. And here's one that I think is really, really interesting. This final one here with a really nice value of 0.9. This is a meta-analysis of therapies for non-chronic depression. So I would assume, I think it's reasonable to assume that non-chronic depression is easier to treat than chronic. I mean, that would be my guess, right? And so what we're looking at here is that even in this case, RO DBT with these really highly dysfunctional multi-problem patient populations is outperforming, at least in these meta-analyses and studies, for easier to treat depression presentations. So hope you can feel kind of confident in RO DBT, at least in this particular area. I'm going to not spend too much time on this one, just in the interest of time. And again, you're going to have my slides, but what you're going to see here is some more specific data on the RO DBT for eating disorders and what the data look like. And again, with the effect size measures being presented to you in the right-hand column. And just to the right of that, for those who aren't familiar, how to interpret those effect size values. And just to let you know that there's quite a bit occurring. There are everything on the slide is already either underway, like sometimes in some cases very far underway. It's not just a theoretical idea, there's movement. So there's manuals being developed for those populations there, for couples, families, adolescents, and specifically for OCPD. Kirsten Gilbert, who I mentioned before, does a lot of child work. She's actually doing a trial with ketamine enhanced RO DBT. RO light. So again, as you'll learn, this is a complicated treatment with a lot of moving parts, somewhat like standard DBT. And so not everybody can, has the time or the money or whatever to participate fully in the full package. So then the question is, can we shorten it in any way? Are there some subpopulations that might benefit from variations of it? That kind of work is being done. Of course, dismantling studies to further understand how each component of the composite intervention work. Continued development of valid and reliable measures of overcontrol. That's a big area of need, actually. Although we do have some options, of course. And a big place where that's occurring is in Brazil. There's a guy named Pedro Pires, I always say it wrong, who's a psychometrician who's doing lots of work there. And then refractory PTSD. And I'm in the midst of working on that with Nate Tomchek and Jimmy Portner in the veteran population. We are going to move beyond research soon, I promise, and get to the actual theory. So I'm wrapping this part up now. So it is an empirically supported treatment under the old Diane Chambliss et al. Criteria. If you navigate to that link, you can get more information regarding that. And as many of you may know, there's a new set of criteria, Dave Tolan et al. Criteria came out in 2015. And basically all the treatments are now being reevaluated under this. Some have already undergone this, but this new criteria, RO DBT has not done that yet. And it's designated as modest. And the reason for that is they didn't feel that reframe trial, there was enough independence of the treatment developer from that trial to consider a truly independent study, so that's like the only thing that was missing. I'm not saying it's only meaning it's small, but that was the reason it got that designation. Okay, let's move into, now we know kind of what the research says, where it came from, the history, etc. Okay, what is it? What are some of the key theoretical ideas? So if we had time, I would take a little poll and, ask you what you thought about the nature of self-control and how important that is to various outcomes, including mental health. And I would imagine that most people would say, well, it's actually, like a pretty important thing. And indeed, if you look at a number of studies, the lack of self-control correlates pretty highly with a lot of poor outcomes. Criminality, impulsive behavior, obviously, by definition. And so because of this, many treatments, of course, are designed essentially to help people achieve more self-control. But the question that sort of emerged in this, not to me, but like to Tom and his early lab, was, is it possible for that to reach a point where it's no longer either helpful, but might even become problematic? So in other words, can you have too much of a good thing? And to go ahead and tell you what the answer is yes, we think so. And so what does that matter? Well, we think that it matters a lot when it comes to treatment. For example, earlier I asked you sort of like rhetorically, what did you think was the most common PD? And I guessed, and I didn't get your answers, obviously, and get the feedback that you probably guessed borderline PD or a cluster B. And why is that? Well, like, in other words, why would you be likely to think that? The reason is because they signal really loudly and largely and kind of clearly. So if somebody with borderline PD, and by the way, I'm not picking on them, they're just a prototypical disorder of under control. So it helps illustrate the point, but my points would apply to other under controlled clinical populations. If a borderline patient is upset, you know it. Like, you'd have to be a total moron not to catch it. Like I'm recalling a client I had a long time ago who came into my waiting room, and like first thing she did was run, sprint, headbutt my wall, and knock herself out. I'm like, oh, she's pissed. Okay. Um, but over control, as we'll talk about, their signals are very muted, and it's partly based on their temperamental biases. So you often don't see their distress. And when they do signal distress, it's often ambiguous and understated. So it's not clear that there's something wrong there. So there's this big divide, right? So like these two groups of people, broadly speaking, are suffering, but there's one group that's really good about letting you know. And there's definitely a chronic imbalance in research, just to show you how big a deal this is. Of all personality disorder research, about 95% of it is done on under controlled patients, mostly borderline and antisocials. Yet the majority of personality disorders are over controlled, right? So you see it all over the place. So this is a problem, because if you assume that every, let's just say, depressed patient is essentially the same, at least in terms of temperament, that leads you to conclude that you might want to approach the treatment in the same way. And an idea I'm going to try to sell you on is that that's actually a big mistake, because there's a difference between an under-controlled depressed patient and an over-controlled one. So let me advance and kind of show you this. So most models, I would say, are basically like this. They have this linear idea that essentially the more self-control, the better, right? The healthier you'll be, and therefore, we will help you learn more self-control. But actually, the data are fairly clear that it's actually probably more of a curvilinear relationship, right? That actually the optimal healthy range to be is kind of in the middle here. But if you're in either tail, then you're going to probably have clinical problems. I think we understand under control fairly well, right? Because I just got done telling you that's how everybody mostly thinks about emotional problems. And what do you need to know if you struggle with under control? Like, well, you need to learn distress tolerance. You need to learn how to regulate emotions, right? You need that kind of thing. But if you're over controlled, which in some ways they have too much of that. It doesn't make a whole lot of sense to then be teaching them emotion regulation strategies and distress tolerance strategies or self-control strategies. You're actually just probably making it worse because they need to learn the opposite, right? They need to actually learn how to dysregulate a little bit, to be a little bit looser. So this is one key idea, is to be thinking about these temperamental dimensions and how they impact how you might approach the clinical issue. And I mentioned I've been using these terms a bit here, but there's broad agreement across many different independent labs that there's essentially two superordinate personality styles, we'll say, that are based on, temperamentally based: under controlled and over controlled. And I'm going to unpack what that means more specifically in just a moment. But broadly speaking, in broad brush, this is how, if we're thinking in DSM terms, you might parcel these out. And again, as I said before, I would say borderline PD is the prototype, right? The most maybe extreme form, you might say, of under control. And then over control, I would say autism or OCPD are probably the prototypes over here. But these are the types of DSM type disorders that we think kind of map over here. There's a few that are like ADHD that can really fall into either. Anyway, let me sort of advance here. So let's talk a little bit more about what do we mean by over control. Essentially, we think there's four broad deficit areas, and these four areas can be basically broken into two broad groups. And these are the four deficit areas that are there. There tends to be a deficit in receptivity and openness, and primarily this means openness to new information or feedback, not just from other people, but from the world, in order to learn and modify behavior as needed. So the kind of closed to new information. Flexible responding, so being able to respond as the context or conditions call for. So for example, if I'm always like hyper perfectionistic, and that is like works really well like in my job, but what happens when I go out to dinner with some friends? I'm not flexibly changing, where it's time to kind of like chill out and joke and loosen up, that might be a problem, right? Emotional expression and awareness. This is a real big idea that I'm going to really unpack shortly, and largely around how they socially signal to other people, not exclusively, but largely with their face, impacts their ability to get connected to other people, which maps into the fourth thing there is they're basically ostracized. They don't feel psychologically connected typically to anybody, and that's what we think is a big problem. So the first two we map onto psychological flexibility, and the bottom two interpersonal dysfunction. Okay, so how do you determine if overcontrol is there? This is a huge topic area that could easily take a multi-day training to really learn, but broadly speaking, there's 4 steps to deriving this conclusion. And of course, you have the 4 deficit areas in mind that you're looking for, and you need to understand the patient population and the characteristics of overcontrol to recognize it. But essentially, we generally recommend you give them some overcontrol relevant scales. And at the current time, there's 3 that we tend to recommend. I was about to say they're all available in the textbook. That's not true. One of the 3 is available in the textbook. The other one, if you buy it, which by the way, I don't make any money on. The other one is the AAQ2, which is freely available, and the personal need for structure, which is also available for free from the author. But the nature of the measures and how they relate are described in the treatment manual. And of course, your regular clinical interview on what you would normally do, but particularly assessing for and identifying disorders that are known to map onto overcontrol would be useful. There may be some supplemental questions that you might want to add to your typical interview repertoire, again, available in the manual, that will help you identify these characteristic personality dimensions. Also highly recommended is something called by the way, the last 2 here, 3 and 4, you do after the patient has left the interview. So you do this afterwards. The OC Global Prototype Rating Scale, So this is a type of measure called a prototype measure, which you may or may not be familiar with. I think mostly about Drew Weston at Emory as like the key person here. The basic idea is that there's descriptive paragraphs of different dimensions. And what you do is you read that paragraph and then you rate how closely you think the patient you just interviewed matches that particular dimension. And then you can derive a numeric value at the end of that. And a lot of the research in prototype measurement shows that it correlates pretty highly with lengthier interviews, like a lengthier SCID-2, for example. And then there's another clinician rated form, again, available in the manual, called the OC trait rating form. There's 8 personality dimensions that you're rating on a Likert type scale, and there is a cutoff score of 40. If you score a patient higher than a 40 on that, you probably have over control there. So let me talk about a little bit more about what we mean by biotemperament and why this matters. So first off, what do we mean when we say biotemperament? Specifically, we mean the genetics of emotion, and in particular, 2 things: how that influences how they perceive the world and how they regulate emotion. Okay. Sometimes that's confused with the concept of a trait. A trait is a combination of both nature and nurture, right? Well, here we're talking about purely a biological phenomenon. And now I've been using overcontrol this entire time. What does this mean? What does overcontrol to under control mean? So let me talk with under control. So under control, in general, they tend to have more of a global processing style. So they're more likely to miss the finer details of things, right? That's kind of the wiring. They have mood dependent behavior, right? So they do things when they feel like doing it, and they don't do things when they don't feel like doing it. It's difficult to kind of plan or act against how they're feeling. They also tend to have high reward sensitivity. So what that means is that the magnitude of the stimulus doesn't have to be very high for them to experience pleasure. That's why they can get very excitable about stuff. Whoa, you're the most amazing friend I've ever met, even though I've only known you for like 10 seconds, right? It doesn't take much. And they have low inhibitory control. Broadly speaking, OC is roughly the opposite of that, right? So they have high threat sensitivity. So that means that they're responding to things as threatening in the environment at lower magnitudes. So it doesn't have to be very high magnitude for them to like be responding as if it's threatening. Relative to people that don't have OC, they have very high detail focused processing. They notice the finer details. They see the trees, but not the forest. Low reward sensitivity. So unfortunately for them, they don't experience a lot of pleasure. Like something has to be really big for it to be kind of pleasurable and exciting to them. And they have very high inhibitory control. Okay. Like anything else under the sun, it's great in certain contexts. Like these are the people that you want probably flying the airplanes that you get on, or performing surgery on you, or building the bridges you drive across, or things of that nature. But if it goes too far and they're not flexible, you might not want to go out for drinks with them or to hang out with them, right? And obviously it's only when it gets into that sort of maladaptive range that it becomes an issue. So all of this is happening biologically, and these responses, these high threat and high detail responses, are happening so quickly. They really can't talk themselves out of it. So I need to speak about that a second. So these kinds of responses, like a threat response, for example, come on within 4 to 7 milliseconds. And so we're clear there's 1,000 milliseconds in 1 second. Okay. For you to be aware of something, conscious awareness, you need between 20 and 50 milliseconds. So the 20 milliseconds are sort of like the Olympians. Like, most of us, it's around 50 milliseconds. So basically, these things are sort of coming on within 4 to 7 milliseconds before you can even know that your body is responding this way. And what do I mean by like the classic example to use is like, you're jogging or hiking and there's like a curvy stick on the ground. And, what do you think how you might interpret that? Like snake, right? your body's responding to it, or your brain is responding to it as a snake at that 4 to 7 millisecond level. It's not until later that you can realize, oh, it's just a stick. But we're responding to other things like that too. And one of the big things we think we're responding to that in this treatment is other people's faces, because other people's facial affects are really unconditioned stimuli. More on that in a minute. But my main point is that we're having responses that are biologically driven very quickly before we can even be consciously aware of it. Okay. And we bring those sort of biases, these perceptions with us in every situation that we go into. And it impacts a number of things. But one thing that we really care about in this treatment is how we socially signal. What do I mean by that? So one of the functions we think of emotion is, and there's many functions, is to signal intentions to people that are not part of your nuclear family, right? So essentially, like, essential signaling whether or not you're a threat, but also the ability to, whether you're someone that they might want to cooperate with and affiliate with. That's one of the things evolutionarily that gave us an advantage, right? As a species, is our ability to cooperate. And one of the ways that we were able to do that is through how we socially signal. That's still very important for us today. But my signaling responses are influenced heavily on the basis of my biotemperament. And I may signal in ways to you that make you not want to affiliate with me. And I'm not aware of it because it's happening so quickly. And you're not entirely aware of the reason either. I don't know if you've ever had somebody in your sphere of life where you're like, there's just something off about that dude. I just don't know what it is, but there's just something. It's likely it could be something like that I'm talking about here. And so because of this, they end up not being able to really kind of connect with other people. So what we think is that over control is a problem of emotional loneliness. These people tend, even though they can't show it outwardly and they can't often tell you about it because of rules that they have and the way that they're made up, is that they're very, very lonely people. And we think they're lonely because they have poor social signaling skills, which is with what I just said. People do not really want to affiliate with them. And so they truly actually are kind of alone. Interestingly, a lot of these people can have a lot of social contact, and you can misconclude that this might not be an issue. But if you dig a little deeper, in fact, this is a good little assessment tip. They might not feel psychologically connected to any of the people that they like. They might go to parties and functions out of obligation. They might have a rule about it, right? Like that's the polite thing to do. I'm in the South, right? That's a big one. It's the right thing to do. And I'm miserable the whole time, right? And I don't really like any of the people that are there. So it would be a mistake to see that outwardly and conclude that they feel psychologically connected. All right. So, and of course, as we all know, under control is a problem of motion dysregulation, completely different issue. So a big thing we're really focusing on in this treatment is people's social signaling skills, with the goal of helping them get psychologically connected to at least one other person. And we believe that that then resolves most of what we're calling mental health issues. So as crazy as this sounds, we often don't target this. As a behaviorist myself, like, this is a really hard thing for me to say. We don't target the actual symptoms that they're coming for. So like in the area of like anorexia, like you've never talked to them about eating behavior. Now, as I understand it, because that's a pretty dangerous condition, like medical people and registered dietitians still are, but like in this treatment, you're not. You're all about getting them back into the tribe, so to speak, by targeting their signaling. And when you do that, the eating problems seem to go away as well as other things. And it's the same thing with every kind of clinical problem, at least the way we're thinking about it. So I've already kind of told you, these people aren't out, starting riots. Though I do want to say it would be a mistake to conclude that they're never emotional, because they can be. It's okay for them to be emotional in places where the rules say it's okay. So like in private or at home or in the therapist office. The other thing that can happen in the community, they can get emotional typically if somebody's violated some kind of moral rule that they have. And a good example that Tom likes to tell a lot is about this guy that used to ride a bus every day. And of course, on the bus, there's like the handicap section. And day after day, he would see this guy who it appeared to not have any sort of difficulties sitting in the handicap section. And that used to really piss him off, right? But he's over controlled, right? He doesn't say anything about it, he holds it in. But day after day, he sees this, and eventually one day he just pops, right? And so of course he then comes to the attention of the police and the mental health, and they think, oh, motion dysregulation. But like in context, not really, right? That's not his baseline. And the term we use for that is called emotional leakage. So they can be emotional, but you need to understand the context in which the emotion kind of comes out. Obviously, they're very hyper detail focused perfectionists. They will tend to prioritize performance over relationships. And they work really hard to prevent most future problems. And they can't tell you about it, though. They don't make a big deal about it. And they're very expert at not appearing deviant on the outside. Again, at least in public. There can be some deviant stuff that they have a lot of shame about, and it's really hard for them to talk about. I won't be able to get into that today, but they will not come across that way, typically speaking. So again, they don't need to be more serious. They don't need to learn how to regulate emotions. We don't need to give them more self-control. In fact, that would be huge mistakes. They need to do the opposite, the things that are correlated with well-being, which is like being able to be loose and be silly and laugh at yourself, right? Different than the way we typically think about it. So, what is the general therapeutic stance and treatment structure? And I am aware of the time. I promise you I will end this on time. The stance is one, and we like to use the sort of metaphor of a tribal ambassador. So the whole goal is to try to get people back into the tribe. And maybe I didn't make this explicit, but we define tribe as at least one other person who will put your needs above theirs. It doesn't have to be more than one. So that's good, right? And I actually think that you can get a level of social network that it can become, at least it does for me, too many relationships to manage, right? And the metaphor kind of works in a number of ways too, in that like it's a way of showing kindness to people who are ostracized from the tribe. It's also like this is what an ambassador would do. You're also a face saver. Like you make it really easy for them to admit some fallibility in a way that's face saving. All of these kinds of things. That's kind of that sort of map on to how you're going to relate to clients here. And then in terms of the treatment, there's four modes, two that are required and two that are optional, very similar to standard DBT. So there's weekly 1 hour individual therapy. And then there's also a weekly 2.5 hour skills training class. And I'll just point out the term class, not group. There's lots of, and that's actually part of being adherent. If you call it a group, that's like you get dinged for that, right? This population on average does not respond well to the concept of group or group therapy. It's a class. You try to get people into the class by the third individual session. And so you don't have to wait on a module or any part of the sequence to get somebody in. You try to get them in as soon as possible. Telephone consultation is made available, although they almost never use it. And when they do, it's typically to tell you about successes, not problems. And then very similar to standard DBT, there's a focused on highly encouraged but not required a treatment consultation team. So what's radical openness? I just need like 2 more minutes. And if you have to hop, I totally get it. And I'm in no hurry either. I'll stick around for people who want to talk. But okay, so radical openness is in essence, it's a confluence of three things. If you were to RO DBT, like a lot of models, has an idea about what psychological health is, and we think that there's three basic components. Okay, one is receptivity and openness to new information in order to learn. Flexible control, so that's being able to flexibly modify across context as the situation calls for, and intimacy and connection with at least one other person. Okay, so radical openness is the confluence of those three things, but it's also this idea that does differ from what you might see in a lot of other cognitive behavioral therapies. Again, we're not about regulating ever, really. And in fact, one thing that's hard for people is there's not validation in the treatment. which is often used to help people regulate, kind of co-regulate, I guess you'd say. It's the opposite. These people need to learn how to not do that, and they're already automatically typically regulating. So the idea is to go again, like you would see in other treatments, to places where people don't want to go, where they want to avoid, but the purpose is different. The purpose is not to regulate or to learn that things are okay or come with a different perspective, but to learn information that would serve this end of being able to connect with other people. The problem that you have along the way is that they're regulating the whole time you do that, or that's like the natural thing they do. So you're always trying to block regulation, basically. So radical openness, it is a skill, but it's also meant to kind of be like a lifestyle that you approach. And one of the key tools in interventions is called self-inquiry, which is essentially where you teach people to pick up on when they have some kind of, and by the way, they don't like emotion words. We tend to use words like, do you have any energy about that? Or, something that sort of signals there might be a place that they could learn something important, or where they're getting kind of closed. And then you teach them to go towards it, and then to do some self-inquiry, which is essentially to ask some questions about it, and perhaps journal about it with a lot of rules around it. And the main rule is that you're not trying to get to an answer, which is what these people are really good at, persisting until they find. You're actually trying to say it's not about getting to the answer. It's about the path, about learning something new, and you never really land there, basically. So it's, as I just said there, the pursuit of the truth is what matters, not the achievement of it. And the goal here, the thought here is that you can't. So in standard DBT, there's the concept of radical acceptance, and the kind of the premise behind that is that there is a reality that you're fighting against. And what we want you to do is learn how to quit fighting reality. The idea in RO DBT is different, is that there is reality, there is like the truth and reality, but you can never really know it. Because in the span of one breath, you can be aware of, research shows, 80 or more things, and even more unconsciously. So it's kind of, we think it's arrogant to assume that I could ever really know what the case is. So that's a big core difference. I won't read these to you because of time. This will be on the slides. These are some classic types of, but not exhaustive list of self-inquiry questions that people might use in their sort of journaling. And I basically said that. Okay, so the last thing I do want to say, to make sure I'm giving you a complete thing here, is the social signaling piece. So basically, I've already told you it's important, and I told you that we signal, at least evolutionarily, to facilitate cooperation and to understand whether or not that people are threatening. We mostly signal through our face. We have more facial muscles than any other species, and we can make about 10,000 different expressions. Believe it or not, most humans only make about 100 or so. And what we all also do, so when we feel something, it shows up in our face, but also we have a tendency through the mirror neuron system to mimic other people, in particular to micro mimic their facial expressions. And it's bidirectional. So as I mentioned a minute ago, if I feel something, it shows up in my face, but also if I manipulate my face, it can have physiological consequences for me. If you're familiar with, like, if we had time, I would do a little brief behavioral experiment where I say, just have a flat face, notice what that feels like, then do a little half smile like you might do in standard DBT. You'll notice something, right? Just by moving your face. So the idea is that you have someone with maladaptive overcontrol who very often are expressionless. You micro mimic that, and that has physiological and emotional consequences for you. It particularly, it feels aversive, and you don't want to affiliate with the person, and you disconnect. What you're teaching clients to do, and what you're also doing as a therapist, is you're learning to socially signal in ways that pull people into their safety responses, which pulls for a desire for affiliation, which then facilitates the whole goal of connection. So that's it in a nutshell, what social signaling is. And so I said this already, right? But we're not going to talk about the target problem. We're really going to talk about social signaling. And this I had left, if we had time, which we clearly do not. I was going to teach you one of the skills for doing that, called the Big 3+1, which I won't do, and I'm sorry that I ran over time. Quickly, if you want to learn more, here's a couple options. On the right, or on the left rather, that's a full day of this, and it's me. It's recorded from a live workshop. If you want intensive training, which if you really want to learn how to do this, you probably would want to pursue. If you go to the link on the right there, you'll see a lot of intensive training options. And then there's absolutely no substitute for getting your hands on these two books. The left one is the actual treatment manual. It does have a lot of the research and stuff in it too, of course, but like the theory and some of the clinical procedures are in there. And then the book on the right is the skills manual that you would use to facilitate a skills training class. And I know I'm way over time. I'm in no hurry. If you have questions, I'll answer it now. If you got to hop, I get it. No offense. You can also contact me or email me with questions offline. You can get me through my website there. And thank you. So I lied. I went about 7 minutes over. My apologies.
Yeah, I think we did have some questions. I know, Carlos, do you want to ask your question?
Thank you, Dr. Lisa. Hi, Trent. Good to see you.
Carlos, oh man, he's my stalker.
I am. I'm a big fan of you. I am. Full disclosure, I am.
I know.
I-
I've seen you in the bushes. Anyway,
Yeah.
what's up?
So I have a question, Trent. I don't know if it's a dumb question, but how much overlap can there be between the two, like the over-controlled style and the under-controlled style? I'm thinking a couple patients where I'm kind of like on the fence where like oh man, is particularly when they have like ADHD or like they seem very over-controlled most of the time, but then they have those um lapses of very overt dysregulation, behavioral and emotional dysregulation. So I guess that's my main question here.
Hey, great question. Unfortunately, it's a really complicated one to answer, but I've got some things that are useful for you. First, let me just acknowledge that sometimes there is some cases where it's not easy to see what the difference is. And I'll point you to a resource, and of course, you know how to reach me. Obviously, I can email it to you. But for everybody's knowledge, there was a special issue, The Behavior Therapist, I can't remember how many years ago, on RO DBT, and one of the articles in there, even if you're not an ABCT member, by the way, you can go to their website, unless this has changed, and you can get these issues for free.
The behavior therapist?
Of The Behavior Therapist, yeah.
Oh yeah, I'm a member. So yeah, yeah.
So then you can get it. So what you're going to want to get then is the RO DBT special issue, and there's one article in there that specifically talks about and has great tips for how to tell the difference between, like in the more complicated cases,
right,
OC or UC. And one thing that's really interesting is something like antisocial PD. There's been some work in the forensic setting. You just assume cluster B, it's under control, where they've actually determined not all, but like many of those individuals are actually probably over controls.
Wow, yeah, that's interesting.
And so that's discussed a little bit in those articles there. So that would be my main tip. But you can talk
I'll
to me
check it out. The
offline.
behavior therapist.
Yeah,
Thank you. Yeah.
you bet. There another one?
I was just wondering, so kind of standard DBT, obviously there's the comprehensive model, right? Some people do individual skills training, but they're not really kind of adhering to the fidelity of the model. So I was just wondering, how does that correlate with radically open DBT?
I think it's exactly the same. It's meant to be the full pack, the full package. I know we talk about it like it's separate, but that is what the treatment is. I think it's reasonable to assume that variations of it or RODBT informed treatment might make sense in some cases, but I don't think we have the data at this moment to really say for sure. I mean, if I were to guess a betting man, I would say it certainly could be helpful. Great question.
I have a question.
Yeah.
Great. It relates to social anxiety work. I do a lot of social anxiety work, and it's kind of a multi-part question. So I see that you list avoidant personality disorder as one of the major over control categories that RODBT has been tested with. Social avoidant personality disorder is essentially severe social anxiety disorder. It's impossible to meet those criteria and not also meet the criteria of social anxiety disorder. On the other hand, most people with social anxiety disorder have the core belief that they are socially underskilled. And yet, actually, their social skills are fine when they're not anxious and engaging in safety behavior. So my concern is if we were to apply RO DBT to social anxiety disorder, which is highly focused on skill development, if that's counterproductive for social anxiety disorder, are there any studies for that?
I'm not aware of any, if I'm understanding you articulated that well. I'm not, but I may misunderstand the key feature of what you're asking. I'm not aware of any studies that specifically address that. I think what I would say is that maybe there's a different way that RO DBT would think about more difficult to treat social anxiety presentations.
Could you expand a little?
Yeah, I mean, I think it would, yes, it's going to be hard to do it in justice. Like, I don't know that there would be a dismissal that clients would have certain regularities and core beliefs and things along those lines. But I think the idea would be that there's a social signaling deficit based on maladaptive overcontrol. It's not to say everybody with social anxiety has maladaptive overcontrol. The hypothesis would be that those that are harder to treat probably do, and that the mechanism for targeting that would be the same kinds of ideas that I'm mentioning here. I heard you express a concern that there might be something that might be harmful or not helpful, and I'm not quite sure I understood what that was.
Yeah, one of the major, arguably the major unhelpful safety behavior with social anxiety disorder, in addition to obviously complete avoidance, but when they're not avoiding,
Sure.
is self-focused attention in a usually highly self-critical way, monitoring themselves as a harsh critic. And I'm just wondering if you were to teach social skills, including, facial expression, doesn't that just enhance self-monitoring and self-focus?
Oh, I misunderstood what you said before. I understand. I suppose it could. I think that's always a risk. I mean, it's just like, it would be like teaching somebody progressive muscle relaxation, not, as a way of like letting go of the struggle, but it could be that you're also simultaneously signaling to them that, hey, feeling anxious is dangerous, which is not what your goal is, right? So I could see that could inadvertently happen. I think that the idea hopefully would be that the way that it's conceptualized for the patient and it's hard to talk to this without telling you some other components, but like the way that you would continue to monitor what they understand the purpose to be, let's just say, and what we're focused on trying to achieve, I would hope that would compete with that risk, but it could happen. It could happen.
Okay, thank you.
You're welcome. That was great. That was great questions.
Trent, I actually had a question. I wanted to circle back to something you said earlier when we were going through the efficacy data, and just the idea that because these patients are over controlled, it might be potentially harmful to teach them emotion regulation as we do in standard DBT. Is there any data on that? Because I'm thinking certain aspects of the emotion regulation training, in particular, how to increase opportunities for positive emotions, and the emotion exposures could target the low reward features of over control, but has there been any data? That's the first part of the question. And then I guess the second idea I had is just like a robust comparison, which would be really interesting. And I wonder if it's already been done, comparing RO DBT for depression and then Michelle Krask's positive affect therapy. And again, it's this idea of getting at the hyposensitivity to reward.
Those are both great questions. So with the first one, I'm not, no, I'm not aware of any data that suggests that it's harmful. I think that's more, and maybe I overstated the case. I think it's more a theoretical thing. That if they, just theoretically, if they have this in excess, that teaching them to do more of what they already excessively have in the repertoire might not make a lot of sense. And I think there is a bit of an inference of when you look at maybe different treatment populations, but they have not generally responded well to existing treatments, where people are kind of doing that, that's sort of like it's a little indirect that, hey, this is kind of evidence of why. But to your point, no, I don't know of any specific data that show if you do that, you're going to be harming people. So sorry for the overstatement. The other, yeah, I'm not aware of that being of RO DBT being compared to Michelle Kraft's work. I think one thing I should maybe tell you that is a little semi-worrisome to me is, you know, Tom doesn't have his lab anymore. Now he has spawned some other researchers who have picked up different segments of this work. So I worry a little bit about the volume of productivity in this work. Like, I think that would be like a great thing to take a look at. I don't know of anybody like Kirsten Gilbert, for example, is pretty productive, but she's all about kids and over control. But great idea.
Yeah, and the reason I'm asking is over the years, because I've been doing DBT, oh boy, since 2003, I have ended up with people who are over controlled in my DBT groups. And I would say, because I do administer the SCID too, anecdotally, I think the most common diagnostic combination is GAD and then OCPD, comorbid. And people in group, you know, anecdotally seem to benefit more from some modules than others. But I have found that there is a real deficit in this ability to proactively create opportunities for positive emotions. And then the mindfulness, non-judgmental stance helps to offset some of the self-judgment and the skill to participate. I guess the closest we're going to get in standard DBT to an aspect of radical openness, like being in the moment. Yeah.
Right. You know, as you're saying that, there's only one thing that's occurring to me, and it's not going to really answer your question, but and this is more theoretical, I think, and hasn't been tested, sadly. So Tom has this idea, gosh, I'm going to botch up the finer nuances of this too, but basically, so don't hold my poor explanation to be a poor accounting of what his theoretical idea is, okay? But that essentially when people are first exposed to things, like say social context, that the immediate effects are a certain type of mu opioids, I think it is. I can send all this to you. I just don't remember off the top of my head, which is appetitive, and so like is experienced as pleasurable, but it quickly shifts to basically an aversive state of affairs. So he has these whole, well, I know you know this, Lisa, but from because you've been through RO DBT training, these types of exposures called participation without planning, and they're all meant to be very brief and spontaneous. So like you know, you get up and you sing some silly song in the skills class, but you limit it to a minute or two, and then it's over. And his idea is that you're doing it just long enough to have sort of the positive effective consequences, but you're stopping it before the aversive stuff can come in. I found the ideas, and I just poorly articulated it, but really interesting and plausible, but nobody's really tested it that I know of.
Well, thank you so much.
You're welcome.
Excellent, really generous of your time.
100%.
Yeah.
So sorry, I had rushed a little bit at the end there. I was watching the clock and picturing everybody hopping off, so I was trying to get it in. But thank you, everybody, for having me. I appreciate it. I'll, as promised, send her the slides here in a few minutes, and she'll send them along.
Great. Thanks, everybody.
Bye.
Bye.
Take care.